Okay, hello everybody. So my name is Dr. Cortland Brown. My pronouns are she, her, and hers, and I'll be moderating tonight's section. I'm very excited about it, and tonight's program will be recorded and uploaded to the AAEM JEDI website within 24 hours. And I'm really curious, I'd love to hear from the audience members where you are at, where you're located right now, where you're at in your training, if you're a medical student, a resident, a fellow, an attending. This Zoom program is set up as a meeting so that we can engage with each other. And so if you're comfortable, you're welcome to come on screen, on and off throughout this session. And these sessions will also meant to be interactive. And so please use the question and answer function. This is my cat, he will be joining us. But please use the question and answer function if you have a question, or you can also just type a chat in the comments. And then I also want to just comment that this is a safe space. We welcome and encourage your participation, and we hope to foster open and respectful dialogues. So I'm going to go over to the chat and see if anybody typed in to say hello and where you're from. And if anybody has any questions or any problems hearing me, just let me know as well. That's so exciting. So we have somebody joining us from Miami, attending as of 2 months ago. Congrats. I just became an attending 2 years ago, and it still feels like it was 2 months ago. So I definitely know the feeling. Oh, another new attendant. That's so exciting. So a lot of people from Florida. I am pretty jealous. I'm in Charlotte now, and it is rainy and a little bit cold. So thank you everybody for joining. So Portland, Oregon, that is very exciting. And brand new attending who finished lots of Florida connections. Well, thank you all so much again. Thank you for joining us. Thank you for listening to what I'm really excited to know is going to be a great talk. So today I have the pleasure of introducing Dr. Alyssa Eily. So Dr. Alyssa Eily is a PGY2 at Mount Sinai Medical Center of Florida in Miami Beach. And she is a vocal advocate for equity in medicine, which started with her founding her medical school chapter for White Coat for Black Lives and continues with her research in healthcare disparities. She actually began a surgical residency and then realized despite how much she enjoyed the OR, she needed a more balanced life with room for more than medicine. And I can 100% relate to that. She then re-entered the match and successfully matched into emergency medicine and is very excited to change the world. And so, Dr. Eily, please unmute yourself and share your screen for tonight's webinar on transgender health. And again, if anybody has any questions at all throughout the presentation, feel free to put them in the Q&A, and I'll also be monitoring the chat.
Self off mute. Hi, everyone. I'm really excited to be here, and thank you so much, Dr. Brown, for that introduction. Let me go ahead and share my screen, and we will get started. Let me.
While we're waiting on the slides, anybody not from Florida or have any Florida connections? Or any other residents or fellows on here? It's really great seeing all of the new younger attendings, and really great that you're interested in this topic because it's so incredibly important. And I think, you know, we don't get much training during residency on it, or definitely don't get enough training. And Dr. Eily, it looks like you're screen sharing, but I don't see the slides. We're just working on getting those slides uploaded.
Perfect. Can you guys see my screen?
Not yet. Working on it.
Mhm.
And while we're working on that, does anybody have any questions right now for how to help gender diverse patients, or any situations that they found themselves in that they didn't really know how to navigate? I know frequently I have made assumptions about somebody's gender identity, and then having to, whenever that person corrects me, or even if they don't correct me, having to kind of take a step back and just, very vocally and honestly apologize to that patient. That's been something that always feels very awkward. And so at the end of the talk, I'd love to hear Dr. Eily's suggestions for that. And if anybody else has any other ways that they navigate that, I'd also love to hear those. Okay, it says has started screen sharing.
There we go. Is everyone able to see it?
Yep, we are. And again, I'll continue to monitor the chat. So if anybody has any questions, please feel free to chime in.
Okay, so once again, thank you all for joining. This is going to be really an open discussion on informed care of transgender patients in the emergency department. I'm Dr. Alyssa Eily. My pronouns are she, her. I am at Mount Sinai Medical Center. I'll graduate next June. And like Dr. Brown said, I did start as a surgical resident and then saw the light, and now spend the majority of my time living in the emergency department. Financial disclosures, I have none. I am a poor resident who is doing this talk because it is something that I care about, not because anyone is paying me to do so. And let's talk about the objectives for today. One, to understand and apply terminology for gender and sexual identities. I think that that is something that we all struggle with, and it leads to some discomfort, and it really impacts our patient care. Two, identifying unique health issues for transgender and gender non-conforming patients. Also identifying potential causes of diagnostic errors when we're treating our transgender patients, and to talk about tools that we can utilize to ensure health equity within the emergency department. So a little bit about me and what I do and why I care. So I am a queer Black woman who has a wonderful fiance and two adorable dogs. But I spend the majority of my time being a vocal advocate for marginalized communities, especially within medicine. So this is something that is incredibly important to me. Why this matters, why this topic. Roughly 0.5 to 1% of our population is trans. So it's not a large subset of our population. Why is it something that we should be passionate about? So I want to talk about the death of TYRA Hunter. So in August of 1995, which despite only feeling like it was 10 years ago, it's actually more than almost 30 years ago. So TYRA Hunter was a trans Black woman in the DC area who was on her way to work when she was in an MVC. She was extricated from the vehicle and was very confused. She urinated on herself, and the EMTs cut her clothing off, as is protocol in any trauma situation, and in doing so, discovered that she had a penis. At that time, they began ridiculing her, calling her a slew of slurs, and spent about 5 to 7 precious minutes berating her instead of transporting her to the hospital. When she arrived at the hospital, the physicians in the emergency department actually refused to provide care. She was a trans Black woman who was automatically assumed to have HIV, automatically assumed to be a drug user, and she died approximately an hour after arriving in the emergency department. Ultimately, her family did sue Washington, D.C. and D.C. General itself and won, and that led to the establishment of a few of the organizations that we have today that advocate for LGBTQ individuals. But it was at the cost of a young woman's life because the providers in the situation weren't trained appropriately. Other reasons that we should care. So there are a lot of healthcare inequities when it comes to transgender individuals. So what we do know is transgender individuals are 5 times more likely to attempt suicide than their cisgender counterparts. And as we know well in the emergency department, we are the first line for acute psychiatric emergencies. Transgender individuals, their HIV rates are about 4 times that of the national average. And trans women of color have the highest rate of HIV of any demographic. This means that they are susceptible to a host of opportunistic infections and other health complications that can be missed, especially when they don't have access to primary care. Also, trans individuals are 4 times more likely to live in extreme poverty. And what we know about the emergency department is we become the de facto primary care, especially for low-income individuals. So what this creates is a situation where we have a demographic of people who we know will not have access to primary care, who we know are at higher risk for certain things. And yet in one study, 21% of trans patients reported avoiding the ED because they were concerned that they would be discriminated against. So in order to have this conversation, we really need to talk about language and gender and sexual identities, which may seem a little bit silly, but I think that it's very helpful for us to have appropriate language when talking with our patients. So this graphic here is really meant to show that there's such a wide array of gender and sexual identities. And the goal is not to memorize them all. The goal is to understand that there is a spectrum and that we need to be comfortable in adjusting to that spectrum and whatever information our patients present to us, and remember to take it with empathy and respect, even though it sometimes may be overwhelming. And I say this as someone who's a member of the LGBTQ community, and still every day there are terms that I haven't heard, terms that I haven't used. So being humble and respecting that fact. So talking about gender identities, we need to remember that these exist separate from sexual identities. Cisgendered individuals are those whose gender identity is consistent with their sex that was assigned at birth. I, for example, am a cis female. Transgender individuals are those whose gender identity does not necessarily match their sex that was assigned at birth. So a trans man would be someone who was born female and identifies as male. Trans female would be someone who was born male and identifies as a woman. There are those who are gender fluid, meaning they exist along the spectrum. They may refer to themselves as transmasculine, transfeminine, non-binary. And then there are those who are intersex, and those are individuals who are born with reproductive anatomy that is consistent with both sexes. Often those individuals have a particular sex chosen for them at birth by their parents. And then let's talk about sexual identities. So heterosexual being those who are attracted to people of the opposite sex. And it is important to remember that trans individuals can identify as heterosexual or straight. You may have a trans male who's in a relationship with a female and identifies that relationship as a heterosexual relationship. Homosexual relationships being those who are attracted to people of the same sex. Bisexual being those who are attracted to the same and the opposite sex. And queer, people such as myself, who are sexually attracted to a spectrum of gender identities. This is a great graphic. It's called the Genderbread Person, and there's a QR code. You can actually pull it up. And what this shows is the intersection between gender identity, expression, biological sex, and sexual orientation. And this shows here that even though they're all separate, they are interrelated. And in order to understand our patients, we need to understand each of these facets. So let's talk about trans-specific healthcare issues and the diagnostic errors that we can make with our transgender patients. So first, we have to understand what gender-affirming care is. So gender-affirming care begins with social gender-affirming care. Those include such things as binding, which is the compression or wrapping of breasts in cis or in transgender females. It can lead to things such as skin irritation, skin infections, and restricted breathing. There have even been cases of individuals developing pneumonia secondary to splinting because their binding is so tight. So this is incredibly important. There's also something called tucking, which is reduction of the testicles into the inguinal canal with posterior displacement of the penis and the scrotum. This can lead to urethral and penile trauma, UTIs, epididymoedemarchitis, as well as testicular torsion. And then there's packing, which involves wearing a penile prosthesis. Now let's talk about medical gender-affirming treatment. Now these include such things as estrogens, anti-androgens, progesterone, and testosterone. This word has a lot of slides on it, so I want to sort of take each one individually. Estrogen is typically used in trans women. And what we do know about estrogen supplementation is that it increases the risk of DVT and PE. This is a little bit less so in those who are using transdermal estrogen, but transdermal estrogen is also not used as frequently as either oral contraceptives or injections. So one of the ways that this may come into play for our transgender patients is we often use the PERC rule to rule out DVTs, PEs. We love using this. It helps decrease the amount of radiation that we're exposing, especially young, healthy individuals to. But if we're not obtaining a thorough history, then what happens here is we may miss that a transgender patient is taking estrogen supplementation and incorrectly apply the PERC rule and potentially miss a PE in these patients. Anti-androgens can cause hyperkalemia, prolactinomas, and overdiuresis. The most commonly used anti-androgen is spironolactone. And one of the big concerns here is hyperkalemia. And there was a reported case of an individual who had not disclosed that they were taking spironolactone, and they were prescribed Bactrim for a UTI and actually came back with a hyperkalemic crisis. Anti-androgens are also associated with prolactinomas, which is important. We see a lot of headaches in the emergency department, and we do our best to rule out any sort of intracranial abnormality with our physical exam and our history. But if you're unaware that anti-androgens can also predispose to prolactinomas, you may not go digging for secondary signs and symptoms of a prolactinoma that would lead you to obtain CT head or other forms of imaging when you otherwise might not and may treat the individual symptomatically. Progesterone, while it is less associated with DVT and PE, is still associated with DVT and PE. So even those transgender individuals who are using progesterone-only supplementation are at higher risk of DVT and PE. Overall, the risk of cardiovascular events in trans women specifically is about 3 times that of their cis counterparts. This means that we're seeing cardiovascular events at younger ages and without the associated comorbidities that we would typically think of. So this means you may have a 40-year-old trans female who's presenting and is actually in the middle of acute coronary syndrome without any other risk factors beyond hormonal supplementation. Because we often don't think of this in our transgender patients, their morbidity and mortality is actually significantly higher, even in cardiac events that could otherwise be treated and stabilized relatively simply. Another thing is osteoporosis. Those who are on testosterone tend to have less rates of osteoporosis, so are trans men. However, our trans women do see higher rates of osteoporosis and pathologic fractures. And without asking questions regarding hormone supplementation, that foosh that we may just think is a foosh may actually be evidence of osteoporosis that gone untreated can lead to further complications such as hip fractures, lumbar fractures that are very debilitating. For trans men who are supplementing testosterone, there's a very high risk of polycythemia, dyslipidemia, hypertension, and hypertriglyceridemia. One of the problems is that many patients are obtaining their gender affirming care not from medical professionals. They are obtaining it via the internet, via the street, and so they're not being closely monitored for potential side effects. And then when they present to the ED with certain complaints, we may dismiss those complaints without understanding the potential complications behind the medications that they're using. There's also surgical gender affirming care. This includes things such as mastectomies, hysterectomies, oophorectomies, vaginoplasties, phalloplasties, and scrotoplasties. While these surgeries are less common than medical gender affirming care, they do occur. And actually here in South Florida, we're one of the few places we have several plastic surgeons and urologists who perform these surgeries routinely. Patients are at risk of infection, wound dehiscence, hematomas, the same way we would see with any other postoperative potential complication. The problem here is that we don't often screen for it. Studies have shown that physicians are much more quick to obtain a CT scan in a postoperative patient who is cisgender than one who's transgender, meaning that there is a high rate of misses in terms of intrapelvic or intra-abdominal hematomas, seromas, etc. The other thing is that patients are more prone to osteoporosis after certain surgical gender affirming treatments. They can have such things as implant rupture, which may go unmissed, and they may have loss of sexual function, which can contribute to their high rates of depression. And so they can present to the ED with depression that was actually precipitated by their loss of sexual function post-surgery. So let's look at the factors that contribute to diagnostic errors. When we look at diagnostic errors, there are three things that intersect: our clinical assessment, our medical knowledge, and our diagnostic reasoning. When those things don't all overlap, that's when we have diagnostic error. And I think what we see most in our care of transgender patients is a limited clinical assessment and a decrease in medical knowledge, which then leads to impaired diagnostic reasoning. The biggest thing is the failure to consider biologic sex-specific pathology. This includes pregnancy and ovarian torsion or testicular torsion. There's also a longstanding history of abbreviated physical exams when it comes to transgender patients, secondary to physician discomfort, limited sexual histories being obtained, or histories that are focused on the patient's transition, irrespective of the relevance to the presenting chief complaint. So then let's talk about tools for reducing bias and improving equitable care. Now, these are two very long slides, but what I want is to take away the overall point. There are a lot of do's and don'ts, but the most important thing here is being open to patient feedback. So, as always, using open-ended questions with patients will help develop a rapport. So using things like, what name and pronouns do you prefer? And also introducing yourself with your preferred pronouns makes a large difference. And I know for cis individuals, this may seem silly or uncomfortable to us. When I say, hi, I'm Dr. Eily, I use the pronoun she, her, how would you like me to address you? I've never had my gender identity questioned. So for me, this feels bizarre. But for those who routinely have their gender identity questioned or who often have to explain their gender identity, that gives them an open space to talk and give you the information that you need. Obtaining a thorough sexual history as it is relevant to the presenting complaint. I think that overall, physicians are not great at taking sexual histories, but especially when it comes to the transgender patient. I always start off with, do you have sex with men, women, or both? Every patient, I ask if they're having anal receptive intercourse, if they're using barrier protection, and when their last STD screening was. By asking these questions to both cis and trans individuals, I think it helps take some of the stigma away. These are important questions, and the answers can lead us down different pathways in terms of our differential diagnosis. And if we don't ask these questions of everyone, we're going to be missing a lot of things on all patients. But transgender patients we know are at higher risk of having HIV, other STDs. They're also at higher risk of interpartner violence. So by obtaining answers to these questions here, we can really tailor our treatment for these patients. There is sometimes hesitance to address what types of gender-affirming care patients have undergone. The way I do this is simply by asking patients what medications they're taking, and then open the statement also with, this includes hormone therapies, over-the-counter supplements. I think we all know that with any patient, you ask them, oh, what medical problems do you have? Oh, none, doc. And then you ask them what medicines they take, and they're going to give you a whole big long list. So for trans patients, this gives them the window of opportunity to talk to you about the gender affirming care they're undergoing without you making an assumption about the care that they're undergoing, or without making it seem like that's not an appropriate topic or that's something that you don't want to know about. And it really normalizes gender affirming care. And the same thing is true for surgical gender affirming care. Have you had any surgeries in the past or procedures to help you align with your gender identity? This way, patients understand that when I'm asking about surgeries, I don't just care about the appendicitis that you had. I also care about your gender affirming surgeries, and that may directly impact my differential. And I shared this information with patients as well. I'm asking this question because if you still have ovaries, that makes me concerned for an ectopic pregnancy. And I think by explaining these things to patients, it makes them more comfortable and allows them to be more open with you. The don'ts. Don't assume a patient's gender or sexual identity. I think we all are guilty of this, myself included. When we do that, we immediately shut down conversation and we prevent patients from being open and honest with us. Don't refuse to use patients' preferred names or pronouns. This may seem, once again, like a silly statement. We use patients' names all the time, and this shouldn't be a big deal, but the reality is that it is. And if you're in a situation where you have used the wrong name for a patient or misgendered them, and they correct you, you simply apologize and move forward. Acknowledge the patient's correction and go from there. Another issue that transgender patients have reported is a focus on their transition when it's not relevant to the chief complaint. Patients coming in for a sore throat, and a physician has gone down a whole rabbit hole wanting to know the intricacies of their gender affirming surgeries, which makes patients feel more like an experiment or a project rather than an individual who's there to seek care. We all love to gossip in the emergency department. How else are we going to pass the time between resuscitations? But one thing that we really need to be careful of is discussing patients' gender or sexual identity with those outside of the patient's care team. Patients hear us more than we realize. And by outing them, even to those in the emergency department who they may never see again, we take some of their power away and we make it less likely that they will seek the care that they need. And the last thing is, don't ignore a patient's symptoms based on their gender appearance. And this is something, once again, I think we are all guilty of doing, even with our cisgendered patients. 75-year-old male comes in with nausea. He gets an EKG right at the door. 75-year-old female comes in with nausea. We're less likely to think about ACS. So when we only think about patients' symptoms in the context of their gender, there's a whole host of differentials that we potentially miss and we can delay care. Physical exams. So always expose your patient as necessary to obtain a thorough physical exam. Overall, I think we do a poor job of undressing patients in general. There's nothing like walking into a room for a patient who's come in for an MBC and is the trauma and they're still fully clothed. So it's important that we are undressing patients to evaluate them appropriately. I, for one, have been guilty of not undressing a patient who came in with chest pain and failed to miss what was shingles. So I went down a whole rabbit hole concerned this woman was dissecting, and it turns out she just had shingles. And if I had taken a look, I would have known. Explain the purpose of your exams. So I do this in general, even with cisgendered patients. I explain to them why it's necessary for a pelvic exam, why it's necessary for a genital exam, so that they understand what I'm looking for. I think it, one, empowers them, and two, also helps them put everything together in the context of their medical care. Offer a patient to have a support person during the exam. Now, I always do this with patients who have reported sexual trauma. I think it's incredibly important. And we always have chaperones in the room, but the chaperones are for us. And we don't often think about the person in the room needing someone there with them. So by offering to have a support person in the room during a pelvic exam, a genital exam, it also gives the patient some power. One thing that I thought was interesting when I was doing some research for this talk was neovaginal exams, which is something I hadn't really thought of, but you can have bleeding, dehiscence, etc., in nouveau vaginas, which require a vaginal exam. However, the anatomy is a little bit different, as is the tissue. So in that case, it's recommended that you actually use anoscopes during the exam versus a traditional speculum. There was also another recommendation to always use the smallest speculum possible, especially for trans men who are on testosterone therapy, who may have vaginal atrophy, and the exam itself may be very painful. Things not to do. Don't expose a patient without consent, which should go without saying and yet doesn't. Comment on patient's body or body habitus beyond what is medically necessary. I think it's important that we remember that our notes are accessible in real time to patients as soon as we hit sign. And so we need to make sure that we're using objective language and medically relevant language. And then never discuss the patient's physical exam with those outside the care team. The patient's physical exam should not be used as fodder or gossip for, the charge nurse's station. And these things may seem silly, but transgender patients have reported these things and reported them as reasons that they don't seek emergency medical care. Two things that I want everyone to remember. One, as we all know, everyone in the emergency department is pregnant or on drugs until proven otherwise. So remember a pregnancy test. There was a 32-year-old trans male who presented to the emergency department in New York. He had confided that he was a trans male, and a pregnancy test was ordered. The pregnancy test came back positive. Even though the test was positive, there was a lack of synthesis of this information to remember that this positive pregnancy test could be related to his abdominal pain. He was triaged as a male with abdominal pain despite the positive pregnancy test, put in a room, wasn't evaluated by a physician until several hours later. At that point, he had started to decompensate. He had a rupture of membranes and had to go to the OR for a stat C-section, which resulted in fetal demise. So remember a pregnancy test, and then remember to use that information in the context of the patient. Also remember to screen for interpartner violence and depression. Transgender individuals have higher rates of interpartner violence, higher rates of suicide and depression. And sometimes we are their only medical care. So by screening for these things, we can help provide them with the care that they need, that they might typically receive from their PCP or their psychiatrist. So then I wanted to go over a couple case examples, and this will require some audience participation. So the first case is a case of shortness of breath. A 32-year-old female presenting patient presents complaining of 1 week of progressively worsening shortness of breath. The patient's chart indicates their name is Samuel. How would you open your examination to foster rapport and obtain a thorough history in order to develop and inform your differential? And I open this to everyone.
I think I would do exactly what you said, which honestly, and I mentioned this in the chat, I have never introduced myself with my pronouns. And now I'm going to do that for every single one of my patients. And so I think I would just say, hi, I'm Dr. Brown. My pronouns are she, her, hers. How would you like me, or what would you like me to call you, and what pronouns do you prefer? And once we've kind of established that, then I'd go into the more of the standard HPI that we consider.
I think that's exactly how I would approach it as well. Once I started using my pronouns and introducing myself to patients, I found that it takes the onus off of the patient to explain their identity. And the history and physical flows much more freely after that. And I find that they provide me with more information when I open that way than if I just say, hi, I'm Dr. Eily, what's going on today? And by doing it with every patient, it no longer makes it a trans issue. It's just a general issue for all of our patients. And in patients like this, once again, it's incredibly important to know what medical gender affirming care are they undergoing. Are they on hormone supplementation? Do we need to be concerned about PE in a patient that we would otherwise say is PERK negative? Have they undergone recent surgery? And these are things that we need to really inform our care and make sure that we are doing right by our trans patients. So this next one here is actually a situation that I had. So a 34-year-old patient presents via EMS complaining of vaginal bleeding. You see a patient with a shaved head and facial hair lying uncomfortably on the stretcher. After placing the patient in the room, the EMS crew begins to loudly comment about the quote man, or whatever you want to call it, end quote. How would you guys address this situation? How would you approach the patient during your history and physical? And then what are key parts of the history and physical that would help you in your differential?
I know that I've 100% had, almost this exact same situation. So I'd love to hear how others handled it or how they think they should handle it. Also just thinking about, when do you step in? When do you step in as that, bystander or upstander? And what's the appropriate way to do it? So would love to hear others' thoughts because this has come up pretty frequently for me.
So I've absolutely seen this on more than one occasion. And with this particular patient, the patient actually wanted to get up and leave and then wound up having a hemoglobin of 6 from vaginal bleeding and required admission. I think that as a resident in general, we feel fairly powerless. And I think that some people may approach it differently once they're in attending, but I do think that residents in general feel powerless and may be hesitant. For me, it actually was coming from an EMS crew that I love. And I was surprised and pretty shocked. An EMS crew that I have a pretty good relationship with. So I was actually able to pull one of them to the side and talk to him about it directly. And it hadn't occurred to him how offensive what he said could be. It hadn't occurred to him how that could impact the patient. And he was actually very apologetic and just admitted, he's like, listen, I don't know anything about any of this. He's like, this is all new to me. I didn't even know this existed. It like just became popular in the news. He's like, I don't know anything about it. And his ignorance wasn't coming from a place of malice. It was literally just that, coming from a place of ignorance. And I was glad that I had such a good relationship with them that I could just pull them aside and talk to them about it. And then in walking into the patient's room, that sort of started a whole nother battle because the patient themselves had already felt traumatized and was already uncomfortable. I think it's a little bit helpful that I have rainbow glasses. I think that sometimes puts patients at ease. And I just opened to the patient. I said, I'm really sorry for the experience that you just had. And just acknowledged what it was that the patient had just undergone as a way to give the patient that safe space for them to talk about it. And also to let them know that when they were under my care, they were in a safe space. And I think that made a huge difference. The patient was, very shocked and upset, but also said this wasn't something new to them, which made me incredibly sad that this was something that they had encountered before. This was a reason that they didn't like coming to the ED or seeking any medical care at all. And this was a trans man who had had uncontrolled vaginal bleeding for quite some time, but was too afraid and embarrassed to go see an OBGYN. So For me, it was just walking in and acknowledging the situation to the patient, and also taking, one of the EMS crew aside and talking about it. And that's something for me, I'm pretty vocal, I feel pretty comfortable doing. I think for those who don't, even if you don't feel comfortable addressing those who are making comments or being inappropriate, addressing the patient and letting the patient know that you are a safe space and that you are supportive can really make a difference. And I see Dr. Swally asked a question. This is an excellent question. So Dr. Swally asks, how do you go about discussing information disclosure with patients who pass for the opposite sex, but do not mention that they are trans? For example, I've had a male patient with abdominal pain who did not disclose they were biologically female and still had internal sex organs, which were found on imaging after. So this is an excellent question. And a little bit difficult. So this is part of the reason that I think that it's very helpful to introduce yourselves using your pronouns, because rainbow glasses and all, there may still be patients that don't know that I'm a safe space to disclose that. So by using your pronouns, it may have opened up that area of communication with that patient in particular. And then I think if you do have that situation where afterwards you're reviewing the CT scan and saying, oh, they have ovarian cysts, I didn't even know they have ovaries, that when you sit down and talk to the patient, really approach it from a place of, I looked at your CAT scan. I want to discuss with you what I saw. I noticed that you have ovaries. Can you please tell me more about that? That way the patient knows that you're not judging them, you're not angry, and it gives them that space to talk. And then you can also explain to them, I understand your identity, your gender identity, you are a trans man, or your gender identity is male. But it's incredibly important for me as your physician to know that you still have ovaries, because that changes some disease processes that I would be concerned for. And I want to make sure that in the future, any physician who's taking care of you has all the information they need to do it well and do it safely. I don't know if anyone else has any thoughts on how to approach that.
I think you're spot on. I think it's really important to kind of say, I acknowledge your gender identity. Because I think my first instinct would be to just say, we saw ovarian torsion, and kind of just to leave it at that, and kind of just to pretend like, kind of just to put their gender identity aside. And so I think it's important to acknowledge that and to say it kind of exactly how you did. So, I acknowledge your gender identity as a transgender male. I do see some ovaries on, or not some, but I do see ovaries on the CT, and so wanted to talk about that. Yeah.
Okay. So key points to take away. Remember that gender and sexual identity are separate entities that exist along a spectrum. Keep in mind that our transgender patients have increased risks of DVT, PE, ACS, depression. All of this should be kept into account when developing your differential. Facilitating a rapport with transgender patients begins the same way it begins with any patient, with respect and empathy. And then never forget to consider biologic sex-specific pathology. And then just remember, wherever the art of medicine is loved, there's also love of humanity. And this picture here is proof. These are my 3 best friends graduating from residency and going on to do amazing things. And I know that they love medicine, and where they are, there is nothing but humanity. If anyone has any other questions, any other things they would like to share in the chat or unmute themselves, go ahead.
And there was just a comment in the chat that I think is a really good point. So I'll just read it. So paying mind to whether or not there are other people, family, friends in the room is important as well. Maybe there's someone else who they don't feel comfortable disclosing that information in front of. And so always being aware of that, and kind of that goes along the same lines of, being very intentional about what you document. And if something is not pertinent to the patient's presentation, not necessarily documenting it just for the sake of documenting it, because who else has access to that chart, and especially for our pediatric patients.
Exactly. And something I actually picked up from one of our old attendings, whenever he would walk into a room, he would say, "Oh, and who do you have with you today?" And that lets the patient say, "Oh, this is my mom," or, "This is my boyfriend," whatever the case may be, so that you have a context for the relationship. And then he would say to the patient, he would say, "If at any point you would like them to step out, please let me know." So also giving the patient the option ahead of time to say, "Oh, I want this family member or friend to step out while, we do the interview, while we do the physical exam." And that wasn't really something I had incorporated into my practice. Truthfully, I was like, I don't, whoever's in the room, I don't care. The patient's there, let me take care of the patient. And I did start to incorporate it into my practice. And I have found situations where the patient is like, "Oh, I would like them to step out of the room when you do the physical exam," whatever the case may be. So it's all about giving people the space and the opportunity to tell you what it is that they need to tell you.
I know one question, I just love to hear everybody's perspectives on this. So, I look white. I'm actually half black, half white, but I do look white. And so I always struggle if I witness, a micro and macroaggression. And in this case, I'll just talk about, race. I always struggle because I don't want to come in as like the white savior. And I don't want to assume that my patient or whoever, was the victim of it can't stand up for themselves. And so thinking about that EMS scenario that you talked about, I never know what the right way to address it is, because should I ask my patient first how they feel about it? Should I put that burden on them when they already obviously have the burden of being the victim of the original micro or macroaggression? Should I ask them how they want me to manage it? Or should I just kind of talk to the EMS person, manage that part of myself, and then, go and discuss things with my patient? And similarly, what if it's a colleague? Because we work with a lot of transgender individuals as our colleagues, as our nursing colleagues, our physician colleagues, techs, everybody in the emergency department. And so I'd be interested to know how you would handle that situation if it wasn't a patient and if it was one of your colleagues also.
I think for me, if it was one of my colleagues, I would probably have been a little bit maybe more aggressive in addressing the EMS crew. With this, I sort of waited and pulled one of the guys to the side. But I think that also very much depends on how comfortable the other individual is with being open with their identity. Because you also, sometimes run the risk of outing other individuals. So it's a very fine line to toe. You may know another individual you work with is gay. You may know another individual you work with is trans, but they may not have disclosed that information to everyone. So sometimes I also just try and approach it as general education for all. Instead of sort of singling someone out when I encounter those micro or macro aggressions, as a way of providing support to another individual and sort of letting them know that I'm there without particularly singling them out and maybe exposing their identity more than they wanted to be exposed. So just, in general saying, "Oh, hey guys, I just read an article about this and wanted to talk about, how we're addressing our transgender patients," or something like that, so that they know that they have a support system in place and they know that they're being advocated for without necessarily being overtly outed.
I think that's great. And then I do have a few other questions because I think this is so interesting. We have a lot of new and young attendings on the chat. So how, Dr. Eily, how has this been incorporated into your residency education, and how do you kind of wish that your attendings would approach this? Should we give lectures on this? Should it be more of a on the shift training? What can we do as young attendings to advocate for our patients and everybody in the transgender community, and how can we help our residents?
I think the great thing about young attendings is they have a whole bunch of ideas and a lot of energy. So I think for the younger generation of physicians, it's really about just creating conversation on shift more so than anything. I think it's those little conversations that you have on shift that actually create change in the culture of where you are. and we have the energy to do so. You know, older attendings have been at this for 20, 30 years. They are just like riding it out, but they're also excited about stuff when we're excited. So it's great to give lectures. It's great to have data and research, but I think more importantly, it's just about having those little conversations on shift. And then slowly over time, people's perspectives start to change. And you'll notice that people start to incorporate new things into their practice and into their process. So the more we encourage those conversations on shift, I think the more lasting change that we create.
Thank you so much for that. I know that I personally, I was actually giving a lecture on transgender health in residency, and one of my co-residents, corrected me because I said, I think I had a patient example that was a transgender male, and I had said female to male, which implies that somebody was something and now they're no longer that. And I think that's a term that we frequently hear, during sign out. And so I started correcting that during shift, and it just starts a conversation. So I think you're 100% spot on. What other questions do our participants have? It's been really helpful to hear everybody's perspective. And feel free to type them in the chat as well. I know one question also that I have, I'd love to hear your tips for approaching any pelvic or breast exams if you have transgender non-binary patients.
So I always explain why it is that I need to do a pelvic exam or why it is that I need to do a breast exam. And I stick to using anatomical terms. I think that takes the sort of like discomfort and the shame out of it. Strictly anatomical terms. I need to do a breast exam. I need to do a pelvic exam. I need to make sure that there's no bleeding coming from the cervix, because when you use the medical terms, there's no judgment implied. And part of the discomfort of trans individuals in the department is that fear of judgment. And so by sticking to those medical terms, you really take away the judgment. And I think that that is incredibly important. And like I said before, offering to let them have someone in the room, and also always letting patients know what you're doing as you're doing it, and that they can stop you at any time. So if I'm doing a speculum exam, I always say to patients, as I'm inserting the exam, if it becomes too painful, let me know, I'll stop immediately. And that gives power back to patients. And when you come from such a marginalized community that has so little power, even those little tiny things that give you just the tiniest bit of power really give you a sense of control and a sense of safety.
Those are all such good points. I'd also just love to hear your thoughts on how do you approach a patient that has kind of what I would perceive as an ambiguous gender identity?
So I think we're just seeing that more and more. The acceptance of people being gender fluid or being androgynous and ambiguous. So once again, opening with your preferred pronouns, and then just simply asking a patient, simply asking. Patients will give you an answer more times than not and be happy to do so and glad that you asked instead of making an assumption. So in that situation where you have someone who is ambiguous, just simply asking, what are your preferred pronouns? Do you have ovaries? Were you born with testicles? Those questions, once again, you're using medical language and asking the question and giving the patients the opportunity to answer. And I think that will get you further in terms of developing patient rapport and in terms of obtaining a good history and physical than anything else.
That's such a good point. And I think in our last few minutes we have together, Dr. Eily, if you have any few take-home points that you want to give to us, I think, there's been so much in this talk. And so it'd be great if there were just a few take-home points that we can just be 100% sure that we all get.
Just remember to ask the questions. Ask the questions in the most non-judgmental way possible using medical terminology, and keep in mind the side effects. Remember that estrogens can provoke DVTs and PEs. Remember that testosterone can cause polycythemia, all things that we learned in medical school, right? But then apply it to your transgender patients. Always remember that everyone is pregnant. Everyone is pregnant. If you remember that, I think it'll solve half the problems. Everyone's pregnant until proven otherwise. And then you will never miss an ectopic pregnancy in a trans man. You will never miss, a spontaneous abortion in a trans man. And remembering that gender and sexual identities are two very different things. And that unless we ask specific questions, we're not going to know. And that will really hinder our ability to do great care and do great work that we're proud of, and save as many lives as we can, which is why we all do what we do.
Well, thank you all so much for joining our session and for sharing your experiences and questions. And please join me in thanking Dr. Alyssa Eily for sharing her expertise and reflecting on her experiences with us tonight. Our next JEDI webinar will be in September, and it'll be a panel discussion for senior residents on the job search for senior residents. And we have an excellent group of individuals that will be there. To register for this and any upcoming sessions, please visit the AAEM JEDI website and select the appropriate links, and I'll drop that in the chat right now. And again, thank you so much for joining us, everybody. We look forward to seeing you again soon. And if you have any questions at all, I'll drop my email in the chat as well.
Thank you all for joining. Apologies for the technical difficulties, but thank you all so much for being here. And thank you, Dr. Brown, so much for moderating.
And thank you again so much. So this ends our session for today, and we look forward to seeing you in future sessions.